So now I want to turn to Chelsea Kelleher at the National Governors Association. She's a senior policy analyst, and really excited to learn about what the National Governors Association is doing in regards to this intersection of opioids and infectious diseases. And just want to welcome also Kip Castner as the member from NGA. So Chelsea?
Great. Thank you so much, Karina and Rich, for inviting me to speak about NGA's work in this area. We're very excited to be speaking with you all today. Before I turn it over to my co-presenter, Kip from Maryland, I'm going to quickly go through a brief overview of who the National Governors Association is, highlight the work that we've done on opioids over the past few years. I'll give you a sense of how governors are thinking about this issue of opioids and infectious disease, and tell you about some new work that we're embarking on in this area. So the National Governors Association is a bipartisan organization serving the needs of governors and their staff. The two largest components of NGA are our Office of Government Relations, which speaks on behalf of the governors in Washington, D.C., and then the Center for Best Practices, which is where I sit. And the center is a 501c3 that operates as a combination of a think tank and consultancy for governors and their staff on a variety of policy issues. As you can see here, we cover education, economic opportunity, homeland security, and the health division where I sit. I should say that we work closely with governors, but also their senior staff, such as health policy advisors and health secretaries, and other state officials in public health, behavioral health, or other agencies that are critical to accomplishing a state's goals in our various projects. Next slide. I won't go into too much detail on this slide, but suffice it to say we've been working on this opioid issue for several years now. Our opioid work is done in collaboration with our Homeland Security and Public Safety Division and with the support of the Centers for Disease Control and Prevention, who have been really tremendous partners to us and to the states over the years. I'll just highlight a couple of things that have been important in this opioid space in the past few years. In July of 2016, 46 governors signed on to a compact to fight opioid addiction, and this was the first time in more than 10 years that the governors had used a compact to drive collective action. And through that agreement, they promised to redouble their efforts in 3 specific areas: reducing inappropriate prescribing, improving education about opioids, and ensuring pathways to treatment and recovery. In conjunction with that compact, in July 2016, we developed what we call a roadmap, which is a tool to really help states assess their current capacity to address the opioid crisis and select evidence-based and promising practices. Following the release of that roadmap, we launched a series of what we call learning labs, which are in-depth technical assistance opportunities to help states learn about and adopt innovative programs or policies that are working in other states. So far we have held 4 of these learning labs, focusing on various different state initiatives, highlighting work that's been done in New Jersey in drug monitoring, Rhode Island's strategic plan on addiction and overdose, New Mexico's Project ECHO program for increasing access to opioid treatment, and then Massachusetts' opioid use disorder treatment model for justice-involved populations. In this coming year, we're launching 2 more learning labs, the first of which I'll be talking about shortly, which will highlight Kentucky's approach to preventing the spread of infectious diseases related to opioid use, as well as highlighting Ohio's MOMS program, which is a program to help improve maternal and infant outcomes related to opioid use. Next slide. So this slide is really just to give you a sense of how governors are thinking about this issue and why this is so important. So I know Rich gave a great overview earlier of kind of what we're seeing in terms of a large uptick in the number of acute hepatitis C infections from 2004 to 2014, really seeing a large increase across the country, but specifically within a couple of subgroups, which Rich discussed earlier. I think we also saw very concerning increases in hepatitis C infections in particular areas of the country. So in that same study, they highlighted that 15 states had seen acute hepatitis infections increase over 500%, and 6 states had seen that increase over 1,000%. So that is very concerning, and I think really catches states' attention to understand where that increase is happening. Additionally, of course, the CDC analysis that identified 220 counties in 26 states with the potential for the rapid spread of HIV and hepatitis C related to injection drug use. And so I think that really underscores the fact that it's not just Indiana where this outbreak could happen. This is many states that have the conditions that could lead to an outbreak happening there. And finally, this, I think, is concerning to governors because these conditions are very costly to treat, and a large portion of that cost falls on state Medicaid budgets. The graphic here is from AMFAR, and it compares the cost of treatment for the historical average of cases in Scott County, which is 5 cases of HIV a year, to the post-crisis cost of 135 cases. And as Joan mentioned earlier, that number has actually gone up over time. It's over 200 cases now. So as you can see, there's really a strong cost component to this as well. And many of the individuals that are at risk for this are uninsured or on Medicaid. And in the midst of the opioid crisis, states are very concerned about costs associated with a potential surge in cases of HIV, hepatitis C, and other costly conditions like endocarditis that are associated with drug use. So this is an issue that's really putting more and more pressure on state budgets and crowding out other priorities. Next slide. So as I mentioned before, we at NGA have just launched a new learning lab on addressing infectious diseases related to substance use. This project will be highlighting Kentucky, which is the first southern state to broadly authorize syringe service programs in 2015. And since then, I believe 41 syringe service programs, which are known in Kentucky as harm reduction and syringe exchange programs, or HRSEPs, have been established across the state. And that visual there just shows you the number that have been established as of last month. In addition to providing clean syringes, the harm reduction syringe exchange programs also provide linkages to critical services and programs, including substance use disorder treatment, overdose prevention, education, and naloxone distribution, screening and care for HIV and viral hepatitis, prevention of mother-to-child transmission, hepatitis A and B vaccination, screening for other sexually transmitted diseases and tuberculosis, and other medical, social, and mental health services. So in addition to learning about the HRSEPs, the states in the project will learn about Kentucky's work on data and surveillance, as well as best practices in treatment for infectious disease and substance use disorder. We are really delighted to be working with 7 states on this project. The states that we're working with are Alabama, Arkansas, Delaware, Michigan, Utah, Virginia, and Washington. So you can see it's a very diverse group geographically and politically. And the states all have different goals, but some common themes among them include a focus on expanding access to community prevention services in rural areas, improving surveillance for viral hepatitis, HIV, and other conditions related to drug use like endocarditis and other infections, and improving access to treatment for infectious disease and substance use disorder. So we will be working with these states for much of this year, and we will, at the end of the project, be disseminating lessons learned through a publication or a webinar that all states are welcome to join and learn from. In our technical assistance for this group of states, we're of course going to be highlighting Kentucky, but we also expect to highlight best practices and lessons learned from other states that have made strides in this area, like the state of Maryland. We think that Maryland is a great example of a state that's really getting ahead of the infectious disease threat by investing in prevention programs and partnering with local communities to expand these services. So with that said, I'll send it over to my co-presenter. Kip Castner is the Chief of the Center for HIV and STI Integration and Capacity in the Infectious Disease Prevention and Health Services Bureau at the Maryland Department of Health. So I'll let Kip take it away.
Good afternoon. Thank you all for this opportunity, especially the National Governors Association and HHS. Next slide. It was in this context of rising overdose deaths that we introduced legislation in the 2016 session of the Maryland General Assembly to make syringe services programs legal statewide, not just in Baltimore City, where they've been legal and operating since 1994. So the legislation passed. It came into effect October 1st in 2016. So since then, we've been promulgating regulations, convening an advisory board, identifying local partners, and providing technical assistance to local partners in their development of applications to operate syringe services programs. Slide. So we're grateful to the CDC for the determination of need guidance. It pointed to a list of non-HIV data elements that indicated the need for an HIV prevention intervention. The guidance has been useful for us to direct counties to these data, particularly in cases where their HIV data don't yet tell the story of needing a syringe services program. So thank you for that. As part of helping Maryland counties gain easy, timely access to those data, our Behavioral Health Administration partnered with our Health Information Exchange to create 2 data dashboards. One is our Prescription Drug Monitoring Program dashboard, designed to help reduce the non-medical use of prescription opioids. The other, that's pictured here, is the Opioid Indicators dashboard, which allows county-level queries and comparisons for overdose-related hospital encounters. These data are also helpful to local health officers as they make the case to other local officials about the need for syringe services programs based on everything that we talked about in the webinar up till now. So we're also grateful to the CDC for creating the Vulnerability Index, which has helped us to establish priority for the western region of Maryland as we stand up new syringe services programs outside of Baltimore City. So here's Maryland in the context of West Virginia and those counties that scored in the top 5%. So the West Virginia counties of Morgan and Berkeley are among those in the top 5%, most vulnerable, and they border Washington County, Maryland. So I'm really pleased that we've received and approved an application from the Washington County Health Department to operate a syringe services program. And congrats to West Virginia on your amazing local response. Slide. So some of you may be facing opposition to harm reduction approaches with traditional arguments like they facilitate drug use. So the main thing that I wanted to offer you today is to share our strategy to counter that. We're finding it successful to teach the stages of change and locate harm reduction programs in that context. So in this slide, we crosswalk the stages of change with the categories of public health intervention. Many, maybe as many as 80% of people who use drugs aren't yet ready for treatment. They're in an earlier stage of change. So we need tools in addition to treatment. And since a feature of worsening substance use is increasing isolation, syringe services programs are essential for sustaining connection to users, both to keep them alive with naloxone and to use the connection to do motivational interviewing to support people through their change process. The Seattle experience with syringe services, as Rich mentioned, has been that participants are 5 times more likely than non-participants to enter treatment, which I think speaks to the significance of meeting and accepting people wherever they are in their journey through the stages. And that sounds like this has been the Indiana experience as well. Next slide. So at this time, we have programs designed to prevent the initiation of drug use, and we have substance use treatment. But for people who inject drugs who are not yet ready for treatment, our public health response is thin. Can you advance? There you go. So we invite you to consider this reimagined landscape for people who use drugs. In this landscape, harm reduction programs meet people in the first 3 stages of change, including those who have relapsed from later stages, and support them where they are. Specifically means syringe services, naloxone distribution, law enforcement-assisted diversion, programs which bridge people on their journey through the stages of change until they're ready for treatment. In Maryland, we are encouraging a comprehensive approach to this problem, and it's working for us to use the stages of change framework to validate harm reduction approaches as responding to the opioid situation at the stages in which people are actually overdosing. Next slide. So here's a look at our progress towards standing up syringe services programs in Maryland. In addition to Baltimore City's program, which has operated since 1994. The Baltimore County Health Department's application was approved last summer, and they're going to go live this spring. As I mentioned, the Washington County Health Department application was just submitted and approved earlier today. Lighter shaded jurisdictions are developing their applications to do this intervention. We require applicants to tell us how they're going to connect clients to other services for which they're ready, such as PrEP, HIV treatment, substance abuse treatment, etc. And our Viral Hepatitis Center is working with Johns Hopkins to train new providers to treat and cure HCV. We're looking to expand HCV treatment capacity anywhere in any jurisdiction in which we're standing up syringe services programs in order to stay ahead of the demand that we expect to find once we start testing more people who use drugs for HCV. Next slide. Thank you again for this opportunity to talk about how Maryland is using data to sell and prioritize syringe services programs and how we're using the Stages of Change framework to dismantle opposition to harm reduction interventions.
Thank you so much, Kip. Also, thanks to Chelsea for reviewing the great work that's going on at the National Governors Association, as well as hearing some specific strategies that Maryland is incorporating. I do want to take just a moment to thank all 7 of the speakers from our partners at SAMHSA, ASTHO, NACCHO, and the National Governors Association this afternoon, and want to move into then a little bit of a shorter than anticipated question and answer time.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.